Next session will be with Dr. Majid Khan. Dr. Majid is neuro and interventional radiologist with a certificate of added qualification in neuroradiology. He is the director of non-vascular spine intervention at Johns Hopkins University Hospitals. Dr. Majid is Associate Professor of Radiology, Otolaryngology, and Neurosurgery at Johns Hopkins. Dr. Majid has contributed to more than 100 publications and book chapters. We're gonna have nice presentation with about imaging of the nasopharyngeal cancer.
Yeah, okay, that's fine. Okay, so let's get started with the nasopharyngeal cancer staging. These are my disclosures. So we'll be talking about nasopharyngeal anatomy, approach to imaging for the nasopharyngeal cancers. We'll go over some nodal disease, which Dr. Allah has already gone over nicely. And then we'll see the differences between AJCC 7 and the new AJCC 8 and what's coming on in the later part of 25 with AJCC 9. So if you look at these two different patients, normal nasopharyngeal mucosa, very crisp mucosa, that you're seeing no nodularity in both these patients. So that's one appearance of nasopharynx that you will see. Here is another patient. Now you have a little bit of a nodularity, which is in the central part of the nasopharynx. Little thickening of the mucosa, which is along the whole length of the mucosa. That's also a normal finding. And this is the T2 of the same image, a little bit of nodularity in the mucosa. You will probably see a little small cyst also developing in the nasopharynx at that level. Now, this is prominence of the adenoidal tissue within the nasopharynx. And here, if you see very closely, you will see these stripes in the AP direction that are typically seen in normal adenoidal soft tissues. And if you give contrast, you will see these, what Dr. Mukherjee earlier said, tiger stripes. So you could probably call them that. And you can see that this is all part of the normal adenoidal soft tissue prominence, but normal adenoids. So these are all the variants of normal mucosa that you may see in a normal patient, and that's the CT correlate of the same finding. Now let's go over some anatomy. So the arrow is pointing towards the most readily visible structure, which is your torus tubarius. Next to the torus tubarius, you have the opening of the eustachian tube. This is the fossa of Rosenmuller, which is more commonly the birthplace of nasopharyngeal carcinoma. Then you go more laterally, you see these dark bands, which are your pterygoid plates, medial and lateral pterygoid plates. This is your longus scoli capitis muscle. Posteriorly, you have the carotid sheath. You have the clivus that of the skull base there. You have the parapharyngeal fat space, you have the pterygoid muscles, and you have the masseter muscles. So all this anatomy that I went over is very, very important when you are looking and evaluating the nasopharyngeal cancer, because our job is to map the tumor for our surgeons so they know, or our treating radiologists, radiation oncologists in this case, so they can map the tumor and they can give the dose to whatever area it needs to go. So this is another patient looking on the normal side, torus tubarius. This is the levator muscle. This is the tensor muscle. This is the eustachian tube, medial and lateral pterygoid muscle. And that's your fossa of Rosenmuller on one side, which is normal. Looking at the fossa of Rosenmuller on the contralateral side, you can see this nodular mass. So what's important? Once the ENT surgeon comes in and they put a scope in through the nose and they're looking at the nasopharynx, they are not going to see any abnormality here because the torus tubarius, which is over it, is going to block their view. So nasopharyngeal carcinoma that is so small, you are responsible for picking them up rather than relying on your ENT to go and pick this up. When they are big, out of the nasopharynx, getting into the nasal cavity and all that, absolutely, they will see it. They don't need you to pick that up. But this is what they need you to pick up. They don't want you to miss this one. So if you look at the world population, overall, Asian population is at about 59% in the world. US, it's about 7.2%, and then in the state of California, it's about 17.8%. So why is that important? Nasopharyngeal carcinoma is more commonly seen in people with Asian descent, especially the Far East Asia. As you can see from this slide, that most common area that you would see nasopharyngeal carcinoma is China, Singapore, Vietnam, and then overall in the world, it's less than 1%, and US, it's even lesser, 0.7%. So what are the three types of nasopharyngeal carcinomas that we see in patients with Asian descent where it's an endemic cancer? So you have the keratinizing squamous cell carcinoma, which is the type 1. It has weak EBV association. The non-keratinizing type 2, most common, strongest association with the EBV virus. And then the undifferentiated carcinoma, which is seen in children and young adults, it also has EBV association. In North America, it's just sporadic, and there is no causality to the development of the nasopharyngeal carcinoma as we have in the Asian population. Almost all of them are treated non-surgically, and as we will go over the T-staging, you will realize that there. So what is the cause of nasopharyngeal carcinoma? Answer is straight and simple. Epstein-Barr virus is the cause. So the virus gets into the basal epithelium of the nasopharyngeal mucosa. It remains dormant there for years and years and years. Then something happens to the virus, it gets activated, and it starts to replicate these basal cells of the mucosa until it reaches the point that the replication of these cells is out of control, and we get nasopharyngeal cancer. We have a good handle on the EBV virus here. You can see an electron microscopic image of the virus itself. We know the sequence of the virus, and that's why it's important that we have good blood assays against this virus. So these are the three viruses that we really know about. The HPV, as we've already discussed in the oropharyngeal cancers and other cancers that we talked about. It is not seen in the blood, but it has a good vaccine, as opposed to an EBV virus, which we have a good blood assay. We can pick it up, and obviously it does not have a vaccine as yet. And these are the different cancers that are associated with these viruses. So when we are going to image a nasopharyngeal carcinoma, MRI is the modality of choice. Yes, CT is done, but CT is done probably at a stage when there is no suspicion of a nasopharyngeal carcinoma, or patient just cannot get MRI. Even if the patient cannot undergo an MRI, we will still do it under anesthesia or something and map the tumor out, because MRI is the modality of choice. PET-CT, just like anything else, would be needed in the post-treatment stage, and it's very, very helpful for nodal metastasis in a post-treated neck. One thing that you should understand is that in an adult, if you see unilateral mastoid sinus opacification and serocytitis media, think about nasopharyngeal carcinoma. Make sure you scan the nasopharynx before you let go of that case. Unilateral mastoid sinus opacification in an adult, scan the nasopharynx. This is a slide. This is not from nasopharynx, but this is a slide because, as I said, that CT can be done in this, and CT and MRI can complement each other. So this is a very good case of that. Here, if I show you this CT, that there's a cancer in there, it was not readily seen on these images. It's hard to see, but if I show you the MRI of the same patient, you know where the cancer is. But CT wasn't completely worthless, because CT did show us that there is erosion of the lateral wall of the orbit. So that was also very helpful, which MR would not have shown us. And then, of course, MR showed us the perineural extension and all going into the rotundum and orbital apex. So really, they can complement each other very nicely in evaluation of the central skull base. So we do, routine sequences are 2D, but we do 3D sequences, especially with fat saturation, to pick up these subtle changes, especially extension along the nerves. So this was a study that was done on patients with nasopharyngeal carcinoma to look at the most common symptomatology that these patients present with. And as you can see, the most common presentation was mass, likely from adenopathy in the neck, followed by nasal dysfunction, followed by oral dysfunction in these patients, and then the other symptoms that you see on there. Now, let's look at the T staging of the nasopharyngeal cancer, because that's very important, and many changes have been made recently to the T stage. So T1 tumor is confined to the nasopharynx. It can extend to the oropharynx or can get into the nasal cavity. T2 is very important now because most cancers that you would see in the head and neck region, if you have involvement of the prevertebral muscles or of the carotid space, you will go to a 4B, inoperable, right? Nasopharyngeal carcinomas, no one really does surgery for this. So hence, involvement of the prevertebral muscles as well as the carotid space keeps the tumor at T2. If you see osseous involvement in a nasopharyngeal carcinoma, any bone is involved in a nasopharyngeal carcinoma, you go to a T3 stage. And then, of course, if you have intracranial involvement, you have perineural spread of disease, you have extension laterally into the orbits or into the parotid gland, and the tumor is extending down through the oropharynx into the hypopharynx, that's a stage 4 disease. So that's, now let's go over each of these stages with some examples. So here you can see the sagittal image. There is some nodularity within the nasopharynx right there. You can see difference there, more nodularity on central and right aspect of the nasopharynx. This was a T1 nasopharyngeal carcinoma. Now this case, I showed you earlier the example of the normal adenoids or enlarged adenoids that can happen in the nasopharynx. No one will tell you if you read this as normal that these are normal adenoidal tissue, but fortunately this patient had this in lower down in the neck, and of course this was biopsied. This turned out to be squamous cell carcinoma with EBV virus. Once you have EBV positivity in a lymph node with an unknown primary, think about nasopharyngeal carcinoma, and multiple biopsies were taken from this, and the biopsies came out to be positive with about 0.5 centimeter primary in the nasopharynx. So, but this is confined to the nasopharynx, so this is a T1. This is very obvious. You can see the fossa of Rosen-Muller completely asymmetric to the contralateral side. This is straightforward T1 nasopharyngeal cancer. This is another one that you're seeing on the contralateral side. It is trying to get into the nasal cavity here. This one has gone into the nasal cavity. So if you draw a line along the posterior aspect of the nasal septum and the mass crosses that imaginary posterior line, you get into the nasal cavity. But we said nasopharynx, oropharynx, or nasal cavity all are T1. So it will still stay at T1 even though it has entered into the nasal cavity. This is a non-contrast T1 weighted image. You look at this, asymmetry on one side, you become suspicious. This is the T2 weighted image, little heterogeneity on that side, and you give contrast, and you can see that there is pretty much irregularity to the mucosa. You have lost the normal contour of the mucosa. So this was an early brewing squamous cell carcinoma, nasopharyngeal, but again, type 1. Again, this is something that they may not look at very carefully early on. This is a big one, as you can see, but it is still restricted by the pharyngobasilar fascia, so it is a T1 nasopharyngeal. So different phases of a T1 nasopharyngeal carcinoma that I'm showing you here. This was actually a medical legal case. So this was a person with familial history of aneurysms and had a small PCOM aneurysm. So they were getting MRI, non-contrast brain, and an MRA on these patients regularly. So here you can see that has definitely some prominence of the adenoidal tissue, but you see there is asymmetry in the fossa of Rosen-Muller. Was missed. Important, what I told you earlier, opacification of the ipsilateral mastoid sinus in an adult. Do not let that go, please. Then this is a year later, you can see the opacification of that sinus has gone worse. And you can see now much bigger mass in the nasopharynx on that ipsilateral side, missed again. This is the T1 of that. You could see very nicely on that T1. Fortunately, this was still within the pharyngobasilar fascia, so even a year after, this was still a T1 disease. And this is now the patient presenting with Horner's syndrome, and that is because it is extending now down into the carotid sheath. And fortunately, because we don't, as I said, we don't do surgeries, otherwise if this was any other cancer, it would have been an inoperable stage 4B, but here it stays at T2, but still it was nonetheless missed for about 1.5 years, and this was finally picked on this MR angiogram image. Okay, moving on. Now again, nasopharyngeal carcinoma, extending into the nasal cavity, very clear, T1, but you have this wispy T2 signal with some corresponding enhancement within the longus colli capitis muscle. Prevertebral muscle involvement makes it a T2 nasopharyngeal carcinoma. So, and now these are few examples here. You may see on this non-contrast that there is some irregularity on asymmetry on this side, but when you give contrast, the ipsilateral longus colli muscle actually enhanced. So this was a T2 nasopharyngeal carcinoma involving the muscle itself. This is again another example. This is the muscle. You can see complete infiltration of that muscle. Again, a T2 cancer. Now this is cancer that is extending more posteriorly, circumferentially around that carotid artery, infiltrating the carotid sheath. Still a T2 cancer in this nasopharyngeal carcinoma, and just showing the post-contrast image also. This is the CT equivalent, another case, another side, and you can see extending all the way back into the carotid, and this is still a T2 cancer. And this is another example of a T2 nasopharyngeal cancer. Now, I said if you see osseous involvement in nasopharyngeal cancer, no matter where you see it, it becomes a T3. So here you can see that there is a little wisp of enhancement within the anterior aspect of the clivus. And on the axial image now you can certainly see that there is enhancement within the clivus. So there is osseous involvement that propels it to a T3 stage right away. Obviously, big time involvement of the clivus. You can see opacification of bilateral mastoid air cells. This is T3 disease. Here you can see involvement of the prevertebral muscle, involvement of the carotid space, still a T2 disease, but you can see enhancement within the lateral mass of C1 vertebra. So osseous involvement propels it up to a T3 stage. Now, this was a very interesting case, and you can see that big, huge mass in the nasopharynx. This is post-contrast image, and now you see some enhancement centrally within the clivus. And this is the corresponding T2 image of the clivus. So, nasopharyngeal cancer, involvement of the clivus, T3 disease. That's what we thought. A PET scan was obtained on this patient, and there was nothing in the clivus. So really, it's a food for thought that are we calling it more than we should be with involvement of the bone in these cancers? Because we know from history that in the oral cavity cancers, especially the lateral tongue cancers that are very close to the cortical margin of the mandible, we do sometimes see some changes in the mandible, and when they go in and they scrape off the mandible, the biopsy comes out to be negative, no cortical bone involvement. So there are possibly some reactive changes that we pick up on MRI, which are not in fact tumors. But in a case, the case that I showed you this, I don't think there's anyone in the room who would not have called this clival involvement. Okay, moving on to the T4 now, and T4, as I said, intracranial, perineural spread, orbits, hypopharynx, and extension laterally way lateral into the parotid gland. So here you can see that is involving the inferior the floor of the central skull base, involvement of ovale. It is creeping up. It is involving the inferior sulcus of the cavernous sinus. Once you have involvement of the inferior sulcus of the cavernous sinus, that is cavernous sinus infiltration. You don't have to go by those three lines, medial, median, and lateral. Inferior sulcus by itself is infiltration of the cavernous sinus. So that's a T4 disease right there. Here you can see big, huge nasopharyngeal cancer extending posteriorly, carotid sheath, but we are seeing the tongue of cancer extending into the superficial lobe of that parotid gland. Parotid gland involvement by an NPC is T4 disease. Another case where you see extension into the oropharynx and actually going down into the hypopharynx, that's T4 disease example also. Straightforward nasopharyngeal cancer, one of the things that it does is that it creeps along the petroclival groove, the cancer. That's really almost like a potential space for cancer to go up, and it has gone up and then infiltrated the cavernous sinus, and you can see now it's circumferentially around the carotid artery, so there is complete infiltration of the cavernous sinus, intracranial extension, so that is again a T4 disease based off of that. And this is sometimes, as I said, you do these CTs, you pick these up, but then you have to go to the MRI to check this out. So here, looks like everything is retained by the pharyngobasilar fascia. I do not have widening of my foramen ovale on this CT. So we go to an MRI, same patient. Obviously, you see some necrotic tissue there. You see enhancement in ovale. And here, when you do your coronal image, you can see enhancement in ovale, and it's trying to creep up. So once you have perineural spread, that is, again, a T4 nasopharyngeal carcinoma. So these are just some examples: bilateral cavernous sinus involvement. This is T4 disease. This is involvement of the pterygopalatine fossa. So that's, again, perineural spread. Rick is going to talk about that, so I don't want to spend some time on this. Again here, complete infiltration of the cavernous sinus, extension laterally in the middle cranial fossa, intracranial involvement, and this is a big, huge cancer that is involving the masseter space also, so T4 disease. This is a big, huge cancer that you can see extending intracranially also, so these are all different examples of a T4 disease. This was a really neat case, and here you can see how the tumor has gone past the clivus. It is into the prepontine cistern, very nicely MRI showing that. This was actually an outside CT was done, and they were thinking that this may be a skull-base osteomyelitis till we got to the MRI, and we said that this is much more than just osteomyelitis, and it turned out to be a nasopharyngeal carcinoma.
2 minutes, Dr. Majid. 2 minutes.
Okay, thank you. Coming to this nodal classification, N1 is unilateral disease, excluding the RP lymph nodes. You can have contralateral RP lymph node and still be an N1 disease. When you have bilateral lymph nodes, you become N2 disease. N3 is when you have lymph node below the level of the cricoid cartilage. And so this is RP lymph node on one side, this is RP lymph node on another side, and contralateral side, you're still N1 disease. Ipsilateral lymph nodes, N1 disease. Now, in this case, you have contralateral lymph nodes bilaterally, so that's straight and simple N2 disease. This is a small lymph node in a patient with nasopharyngeal carcinoma at the level of the cricoid cartilage. We are not below the level of the cricoid cartilage. So if this is unilateral, this is N1. If it is bilateral, this is still an N2 disease. As opposed to this lymph node, which is now below the level of the cricoid cartilage. So this becomes an N3 disease now. I already touched on this. You do a nodal biopsy which shows squamous cell carcinoma. They do all their testing. They don't see anything. We do a CT. We don't really pick up anything. The node comes back as EBV positive. We have to assume, till proven otherwise, that the primary is from nasopharynx. What are the changes that have come in AJCC 8? As I said, The prevertebral involvement, the pterygoid involvement is now T2 compared to previously in AJCC 7 was T4. The caudal border of the cricoid cartilage replaces the term supraclavicular fossa lymph node for N3 disease. And previously we were dividing N3 into A and B, but now they have just lumped it together into just N3 disease. So this was AJCC 7. You had the lateral pterygoid was N4, but now you can see in AJCC 8, lateral pterygoid has come in T2, while as the masseter still remains as N4. And what's coming new in 2025 is now extranodal extension in a lymph node in patients with nasopharyngeal carcinoma. It will become an N3 disease now. And then they are further dividing the metastatic disease into M1A, which has less than 3 lesions, versus MB, which has more than 3 lesions. So here is an example. Big cancer, lymph node bilaterally, would have been N2 disease, but we have extranodal extension, so it's an N3 disease now. Everything you see in nasopharynx is not nasopharyngeal carcinoma. This is MPNST. This is very, very dark on ADC image, so this is a lymphoma. This is another tumor that we see in the pharyngeal mucosal space, which is an adenoid cystic carcinoma. And finally, do not forget about skull base osteomyelitis, also can happen in there. Thank you very much.